Good evening, everyone. My name is Matthew Carver. I'm a product specialist here at OCULUS. Welcome to tonight's clinical webcast, Building and Managing a Dry Eye Clinic of Excellence. You have a text box on your GoToWebinar screen where you can enter questions. Feel free to type in your questions during or immediately after the presentation, and we'll have some time to discuss them at the end of tonight's webcast. Our speaker tonight is Dr. Marguerite McDonald. Dr. McDonald is a board-certified ophthalmologist. She received her medical degree from Columbia University College of Physicians and Surgeons, followed by an ophthalmology residency at Manhattan Eye and Ear Cornell program in New York City, and a fellowship in corneal and external diseases with Dr. Herbert E. Kaufman at the LSU Eye Center in New Orleans. She is currently working at OCLI, a multi-location ophthalmic practice in Long Island, New York. Dr. McDonald is a clinical professor of ophthalmology at NYU School of Medicine in Manhattan and is also an adjunct clinical professor of ophthalmology at Tulane University Health Sciences Center in New Orleans. In 1988, after years of research, Dr. McDonald performed the world's first laser vision correction procedure, K. Dr. McDonald has over 1,800 publications on refractive surgery, the cornea, ocular infections and allergies, and ocular surface disease. She was the first female president of ASCRS and was the first, and still the only, female president of ISRS. She has received many awards and has been honored with the selection to the editorial boards of several publications, including the Journal of Cataract and Refractive Surgery and the Journal of Refractive Surgery. It's an honor to have Dr. McDonald with us tonight on the webcast, and on behalf of Oculus, I'd like to express our gratitude for her time and efforts. I'd also like to thank everyone in attendance for your time tonight. Without further delay, I'd like to welcome Dr. Marguerite McDonald.
Thank you, Matthew. That was a great introduction. So we're going to talk about building and managing a dry eye clinic of excellence. So these are my disclosures. And to get started, this is really how we did it, and it worked really well. A lot of the advice is sort of a mixture of implementation advice as well as clinical and scientific factoids. So first, identify a dry eye center of excellence that's 50 to 75 miles away. Why this distance? Far enough away that they won't be threatened by you. They'll be willing to share all their knowledge with you. You're not that close, but close enough that you won't need to incur the cost of airfare and meals because you're going to go with your practice manager and your chief tech. So you can get there in one day, watch for a good part of the day, and get home. Maybe with one stop at the Cracker Barrel for a snack. So you're limiting your expenses. Be really considerate. Having visitors is going to slow your colleague down very significantly and rob him or her of any chance to answer email, talk to, or text the spouse, whatever, because you're going to be sticking with them all day long. Ask in advance if you can order lunch for the office from their favorite restaurant or deli, and they'll be smiling when you come in. So observe your colleague with your chief tech while your office manager goes to the business office and gets as much information as possible about billing, etc. But once again, be sensitive. Some practices won't share financial information freely, even if you're from 1,000 miles away. Some will. Shadow the techs and coordinator. Everybody should carry a notebook or take notes on their smartphone. You don't want to be calling back later. What did you say? I didn't remember what you said. And afterwards, send a gift with a note, a bottle of wine, some nice cheese, something thoughtful. So you get back home and you start with a team meeting with everybody to let the staff know that this is important to you for the benefit of your patients and for the health of the practice. They're not mind readers. You're going to be putting a little more duties and work on their plate. You have to explain this is going to help our patients, going to help our surgical patients, and it will be good for the bottom line of this practice. And you can explain if you want me to continue giving bonuses and raises to you all as I would like to. This will help. So that builds enthusiasm. And you can start marketing with the most inexpensive tools you can imagine, but they're highly effective. If you have staff walking around wearing a big button that says, ask me about dry eye, that makes a difference. One sheet tucked in with your invoices. When you send out your invoices via snail mail, just stick in one extra sheet announcing your Dry Eye Center of Excellence. And then, of course, posters on the walls of the exam lanes, the dilating area, the lobby. This costs, all of this probably costs less than $25, and it has huge impact. But also rely on industry. The vendors are all dying to help us. Our success is their success. And they are marketing experts. We are not. Most of us were science majors. We're not wordsmiths. They've got advanced degrees in this. Let them in. Throw the doors open, let them in. Don't reinvent the wheel. They've got press releases. They've got trifold brochures. They've got everything, video links for Facebook, everything. Just let them do it. So in the clinic, start with questionnaires, osmolarity, and MMP9 testing first. So why? A positive questionnaire, use one of the very short but validated questionnaires like the SPEED questionnaire. If you get even one question ticked off in the positive, indicating that the patient might have dry eye, this allows your tech to proceed with ocular surface disease testing before you go in. Nobody wants to go into that room twice. So hyperosmolarity is actually the central core mechanism by which dry eye disease damages the ocular surface, so it makes sense to start with tear osmolarity. And MMP9 testing is the first and only rapid CLIA-waived test that detects MMP9, which is a biomarker for inflammation. It is consistently elevated in the tears of dry eye patients. So just a little more about why to start with it, with tear osmolarity. It's objective, it's fast. It really aids in diagnosis and in tracking response to treatment. You tell people, oh, you used to be 350 and now 3 months later, your tear osmolarity has dropped to 298. People love numbers. It's very easy to implement and there's a relatively small capital investment. So a real quick tip, have a unit in each exam lane if you possibly can. For every extra step your tech has to take to use it, it will get used less. And also, since it's a pretty fast test, it really helps you with patients where they have no symptoms. They didn't check off anything on the questionnaire. You go in and you find heavy SPK. You know they have dry eyes. You can, if it's sitting right there in the exam lane, you can quickly, within seconds, get a number. And when they say, I don't have dry eyes, I don't know what you're talking about, I don't have any symptoms, you say, yes, but your score is 380. You're about to make my machine go tilt. That gets their attention. So I mentioned MMP9 testing as another thing to start alongside tear osmolarity. Why this? MMPs, matrix metalloproteinase 9, this group are proteolytic enzymes that are produced by stressed epithelial cells on the ocular surface. So if you identify elevated MMP9 levels, or basically you're identifying inflammation, it helps guide therapeutic decision making. An increase in their MMP9 level means this patient might respond to anti-inflammatory therapy. And it's also a very small capital investment. And this just shows on the left, a positive result has a blue and a red line. The red line can be very faint or very bright, but that means, whoops, it just advanced on its own. Let me go back. So a positive is a red line of any intensity. On the right, you see a negative test result. This is a blue line. That means enough tears were sucked up into the cassette for it to be a valid test, but it's negative. So when everybody's comfortable with these two tests, which will be very quick, it's easy, within a few weeks, you'll be able to add another diagnostic, a very important one, the ability to perform meibography. A picture is truly worth 1,000 words. You can tell someone they have advanced ocular surface disease till the cows come home, the picture means everything. So it helps the doctor for grading the level of OSD and decision-making about therapy. But as I said, it really helps the patient understand their disease, and it increases compliance tenfold. So here is the Oculus Keratograph 5M. It performs meibography beautifully, as you'll see, but it also has a topographer and 5 ways to measure the tear film. And it's made by Oculus USA. It's not a huge unit. You see here, it's on a tabletop, not a big footprint. So just to elaborate, it's a very advanced placido-based corneal topographer. It has a real built-in keratometer. It has a color camera that's optimized for external imaging. And besides meibography, it performs non-invasive tear film breakup time, which I love. That also impresses patients. Tear meniscus height measurement and evaluation of the lipid layer. So here's another shot of it. And just to elaborate on exactly how it helps in anterior segment comprehensive and corneal practices. First, it's got 4 illumination systems, depending upon the task at hand. So it's got a white placido ring and an infrared placido ring lighting system. It's got infrared LED lights, blue LED spots, and white LED spots. So it also has 3 levels of magnification depending on the task at hand. You either get a 10 millimeter, 15, or even a 26 millimeter view of the eye. And the topography is excellent. It also gives you automatic horizontal, visual, iris diameter, HVID, which is basically an automatic white-to-white measurement, and automatic pupil measurements. So specifically, what does it do for ocular surface disease evaluations? So we all know, because of the classic study by Mike Lemp, that of the dry eye patients he studied, 159, 50% had evaporative dry eye, 36% had evaporative and aqueous mixed. Only 14% were aqueous deficient. So the vast majority of the people we encounter will have mixed or evaporative dry eye. Kelly Nichols has a similar paper, and instead of 86, she came up with 92% are evaporative or mixed. So, very few people really with pure aqueous deficient. We're dealing with blepharitis and dry eye combined. So the Keratograph 5M assesses tear film quality. It will very accurately measure the tear meniscus height for you. And not only will it analyze how quickly the tear film breaks up and where, it analyzes the thickness of the lipid layer, because the more top right, the more colors there are, the thicker the lipid layer. A very gray appearance indicates that the lipid layer, the tear film itself, is thin. And on the bottom, all of us have little bits of debris in our tear film, little bits of dried mucus, little bits of broken cilia. Women have little bits of makeup. And the Keratograph 5M can identify these little bits of debris, and in between blinks can track the direction and speed with which that piece of debris moves, which has direct bearing on the viscosity of the tear film. So here's the non-invasive Keratograph breakup time. I use this a lot with patients too. So, a nice, healthy, normal young person, you could hold their lids open and you'll see green everywhere, because that means their tear film is not breaking up even after holding their lids apart for 24 seconds. But here you see this patient has significant dry eye. Some of it is so dry it's not even integrated, but you see the yellow, orange, and red colors indicate the number of seconds it took for that tear film to break up. And bottom right here is a graphic representation of the tear film breakup time. So you've got a picture of what a healthy young eye looks like, and you show them their map, how fast their tear film is breaking up, which explains their visual complaints. So very, very useful visuals for patients, and numerics. which impress them as well. So this just shows the blink, and you can see the debris that's slowly floating upward between blinks, and the direction and speed with which the little bits move has direct bearing, as I said, on the viscosity. Automatic assessment of bulbar redness. This is terrific. There's an independent automatic grading of the conj erythema, which is top right, and you can isolate just the limbal area to grade ciliary flush in someone who has iritis, for instance. You can track if it's getting better or worse automatically. Meibography, which I truly love. So meibography, we know we're all born with 140 Meibomian glands vertically oriented and distributed amongst the four lids. And they're supposed to be nice and tall and straight. And when you have blepharitis, Meibomian gland disease, they become altered, as you'll see in a moment. So bottom left is a healthy looking eye with minimal Meibomian gland disease, virtually normal. Then as you move across to the right, you see truncation. The glands are dropping out. It usually starts nasally and moves temporally. The glands become inspissated with altered meibum, truncated, and finally they drop out. And the bottom image on the right and the top, the image right above it, show extremely severe, almost end-stage Meibomian gland disease. The external photography is fabulous for fluorescein imaging. So it is actually possible to independently grade how much SPK they have. And that's a way to track response to treatment, of course. And the external photography is exquisite. You see this high fidelity picture of lissamine green staining in a patient with dry eye. And this is impressive to patients. You show them, they're not supposed to be any green here. And this shows that your conjunctiva has dry spots and is in trouble. So I mentioned external photography of the lipid layer. And here now we're concentrating on the colors. So the more multi-hued, the thicker the lipid layer and the more normal and healthy the tear film. And that can all be graded. And this is a fairly healthy eye. Now, you can just point out the one or two tests you want to show the patient, or you can print out a report that they can take home. And Oculus will make sure your practice logo gets put on there. And some patients really like this. Intuitive grading scales, easy for them to understand, a description of the tests for the patients, and the treatment plan. And there are other reports that Oculus can give you, including something called the Genvis report, which gives all this information in a spider plot. So some people like this, some people don't, but more and more dry eye centers of excellence send their patients home with something like this. So back for a moment to Meibomian gland imaging. So like I said, it starts nasally. So bottom left, you see there are some missing glands nasally, even though this is very early stage, non-obvious Meibomian gland disease. Then now in the middle image, you see the duct dilation, the inspissation and gland constipation, curling and shortening, and finally, over far right, severe gland loss. We don't want anybody to get to that stage because these people are virtual house prisoners. They have such severe light sensitivity, they can't really drive. They mostly stay at home and they've got their curtains and their blinds drawn. So we don't want anybody, and I'll say that to patients, you're like the middle here. We don't want you to get, without treatment, you will end up like the far right picture. Very motivating. So now you've got your diagnostics, some of the best constellation of diagnostics. Now time to add some in-office therapeutics. So once again, you can stick your toe in the water with something like a professional lid cleaning with a swab stick. So OcuSoft has these. And you squeeze the shaft, and it delivers, the shaft has fluid in it, it delivers fluid to the sponge tip. And you can have the patient sign an ABN, and you charge for it. And you or your technician clean their lids in the office. They also have one with so this has clear fluid in the shaft. They have one with yellow fluid in the shaft, which has tea tree oil and various other things, other oils, sea buckhorn, etc. And it's designed to treat blepharitis and Demodex. So that's a great way to start. And it's easy, and you really can't hurt anybody with this very thick swab stick. Then you can move on to microblepharoexfoliation. This is the BlephX unit. And some doctors do it themselves. Some train up their technicians. The offices where the doctors do it generally charge a little more because the doctor's time per unit hour is greater than the tech's. But this is great. We do a great deal of this, and we actually do it in combination with thermal pulsation therapy, which is the LipiFlow treatment now from J&J Vision. Now, this is just for illustration. The vast majority of people have both eyes treated at the same time. So the lids are warmed and massaged. It's a very pleasant feeling. I get it done every 12 to 18 months myself. And all the altered meibum comes out into these activators, and they get thrown away. And the cornea is totally protected. There's no heat transfer to the cornea at all. Actually, this vaults over the cornea. It doesn't touch the cornea. So if you do the BlephX first, you're opening all the Meibomian gland orifices. That's 8 to 10 minutes. And while the patient's in the same chair, we just move right into thermal pulsation therapy. So they're in the chair for a total of 22 minutes. When I usually, in our practice, I do the BlephX treatment, and I put in the activators and leave. And a technician stays behind with them. You can't really leave them alone because they've got both eyes occluded. Every once in a while, we get somebody who is claustrophobic, and they insist on each eye being done separately, but that's actually very rare. As long as you leave a technician in the room to chat with them, they're fine, and it works beautifully. IPL treatments, intense pulse light, is another in-office treatment that's quite popular. And there's also ILUX, recently acquired by Alcon. This is another in-office therapeutic, a light-based heat and compression treatment under direct visualization. So the doctor or tech is looking at a magnified view of the lids, and the ILUX is just moved along, and the lids are warmed and heated, and the altered meibum is expressed. There is also Cheer Science, and this has the advantage of the patient having his or her eyes open during treatment. So it's another way to heat the Meibomian glands, and both eyes are done at the same time. But because the patient's eyes are open, claustrophobics are not bothered. Most patients just look at their iPhone and answer email for the 12 minutes of the treatment, and a tech does not have to be there with them. You would leave the door open, so if they called, somebody could dash in, but they don't need to be babysat for this in-office treatment. So you're going to slowly but surely add additional technologies. And as your reputation grows, increasing numbers of extremely dry eye patients are going to seek you out. So you're going to have to stock up on lots of punctal plugs, lots and lots of plugs, and amniotic membranes. So severe dry eye patients with non-healing epithelial defects and ulcers do great with the placement of an amniotic membrane. More about that in a moment. Find a source for serum tears. So severe dry eye patients do beautifully with serum tears made from their own blood. It is not something that everybody wants to get into. I think our practice is the only place left in the tri-state area where you can get serum tears from an eye doctor. There are eye banks and blood banks that have gotten into it, but every Wednesday in our Garden City office, we produce serum tears, and we give people an appointment. They come in, it gets done very quickly. They get their tears off, they go. And we have people from all over the state of New York, New Jersey, and Connecticut who drive in for the serum tears. They're loaded with growth factors, loaded. Speaking of which, nerve growth factor is something that you'll get into as your dry eye center of excellence becomes established. And I'll more about that in a second too. So here's a picture of an amniotic membrane that I use a great deal of. It's called a Procara Slim. It's a gigantic 24 millimeter PMMA ring, very thin, with an amniotic membrane cryopreserved, suspended across it. Patients, if they're wearing it, their vision gets knocked down a few lines. So we usually, because it's a translucent gray, we usually leave it in for 5 days, take it out, put one in the other eye. I have done both eyes at the same time in severe patients, especially those who are retired. And some people need a series of them, 2, 3, 4 in a row, and then you can stop. But most patients, even the severe dry eye patients, get one of these like twice a year. And it's like a booster shot. And because the amniotic membrane has fetal growth factors, such as heavy chain hyaluronic acid and pentraxin 3, for the 5 days that they're wearing this day and night, it drives massive amounts of fetal growth factor into their corneas and their conjunctiva, and it tunes them up, and they're okay for a while. I have lots of patients who come twice a year. It's time for my amniotic membrane. So a word about nerve growth factor. A lot of dry eye patients, severe dry eye patients, end up with neurotrophic keratitis, and neurotrophic keratitis caused by other etiologies can give you dry eye. So eventually you start to get a cohort of people who have NK, neurotrophic keratitis. And thank goodness, there is something we can do about it now. The FDA in August of 2018 approved recombinant DNA endogenous nerve growth factor. So, and the nerve growth factor is responsible for cell proliferation, tear secretion, and corneal reinnervation. And the approved product is called Synagermin, otherwise known as trade name Oxervate. And it's recombinant DNA technology. We've known about NGF since the early 1950s. A scientist won a Nobel Prize for this, she and her team. And I probably have now got about 30 people on this, and I have to say I'm extremely impressed. And they take it 6 times a day for 8 weeks. That's considered a course. I have a small percentage of people who needed a second course. So they get 8 weeks, we give them a break for a few days, then another course of treatment. That's something you need in your armamentarium if you get into this in a big way. There are also new therapeutics for at-home use, including new lids. And these are generally sold through doctors' offices. So it's do-it-yourself home BlephX, basically. Of course, BlephX by the doctor is an extremely effective treatment. But the published data on patients doing this at home for themselves is quite impressive. And there's a little disposable spinning tip with soft little fingers. No one in the clinical trial had even the tiniest abrasion. So that is catching on. And I think it's a good idea to stay in touch with that colleague you visited. You may want to go back at least one more time, a few months or a year later. And there may come a time when they want to visit you. But usually, if you go back a few months later after you've already got your center up and running, you will see things you didn't see the first time. And it's just one more stop at the Cracker Barrel. So in conclusion, it's really good medicine to treat dry eye disease. We have so much better diagnostic technologies than we did a few years ago, and treatments. And this leads to happier patients and better surgical outcomes. It's very low risk, medical legally speaking. The visits and the in-office treatments greatly enhance your bottom line, and the comorbidities also enhance your bottom line. Older patients get dry eye, but they also get cataracts it is a misconception that focusing on dry eye will somehow cannibalize your cataract business. My cataract volume went up dramatically when I got into dry eye in a serious way. So if you are interested, this is the information for the Oculus sales and service and the phone number and their websites. And before I turn it back over to Matthew, I want to thank you all for spending part of your afternoon or evening with me. So Matthew, the floor is yours.
Perfect. Thank you so much, Dr. McDonald, and thank you everyone for attending. We'll get to some questions in just a moment. Just a reminder, on your GoToWebinar screen, you have a text box for typing in your questions. If you enter them now, I'll be able to read them off to Dr. McDonald. If you missed part of the webinar, you'll be receiving a link to the recording tomorrow. The Keratograph 5M Ultralight captures meibographies, the tear meniscus height and NIKBUT, and is sold for as low as $17,000. If you're interested in purchasing a Keratograph 5M, or if you have any questions about tonight's webinar, the Keratograph 5M or the Crystal Tear Report, you're welcome to contact us at the 800 number shown on screen. Or you can email us at sales@oculususa.com. We also have prior webinars like the one tonight available on our website at oculususa.com. Let's get to the questions. So we've had a few people ask this. They're wanting to know, how do you get started with serum tears treatment? What equipment do you need? And the best cases, like what sort of load should you get before starting those treatments?
What sort of, did you say load?
Like patient volume.
Oh, okay. So as time passes, people will come from further away with more and more severe dry eye disease. So if you have somebody who's on Restasis and Xiidra, and about 20% of my patients are on both, they're so dry, and they're on preservative-free tears every hour while awake or every 1 to 2 hours, and they're taking ointment at night and omega-3s, and you have, really kind of maxed out your treatment. A very high percentage, as I mentioned, 86 to 92% will have Meibomian gland disease as well. So sometimes the nighttime ointment is erythromycin or even bacitracin. So, the DOs, by the way, the treatment schedules are all extremely similar. So there's DOs recommendations from the dry eye workshop number 2. There's the Meibomian gland disease workshop. There's the Cedars Aspens guidelines. There's the Ascaris guidelines that came out last year. They're all remarkably similar. So if you find yourself up at the top, soaks and scrubs twice a day, the ointment at night, the tears every 1 to 2 hours while awake, preservative-free, omega-3s, everything, and they're still miserable, you move up the treatment ladder to the serum tears. So you need a class 100 clean room, you need a trained phlebotomist, you need a lot of things that most offices really don't want to get into. There are eye banks and blood banks that get into this. There's almost always somebody in the area. If you happen to be within driving distance of us, we do the serum tears for other people's patients. We don't steal them. We just let them come in, get their serum tears, and go back to their homes and their doctors. But because the serum tears, so they draw the blood, spin it down, they mix the serum 50-50 with sterile saline. And depending on how frequently they take it, it lasts the average dry eye patient usually 3 months, each blood draw. Some people are so dry, they're going through it every 4 to 6 weeks, but even in my practice, that's rare. They have to keep it cold. This is a giant problem. It's preservative-free. I tell patients that they should get a Frigo pack, F-R-I-G-O, a Frigo pack. Every drugstore sells them without prescription. They are a little tiny ice pack that diabetics keep their insulin syringes in. You put them in the freezer, and and the serum tears can get tucked in the same space that the insulin syringe would have been in. They will stay cold all day long, and they fit into the tiniest purse. Maybe an evening bag wouldn't fit it, but it fits easily into the average woman's purse and the average man's briefcase. So the Frigo pack has made it possible to carry serum tears all over and live a normal life without dragging an igloo cooler with you. Of course, if you get to work, you can take your Frigo pack and, put it in the fridge, but FRIGO, it's been a lifesaver for our many dry eye patients.
Perfect. Thank you so much for that in-depth answer. I have someone who is wondering, is there a particular order that patients need BlephX, IPL, and LipiFlow, or can you do them in any order?
Well, very good question. Usually they went on the treatment ladders, the treatment schemes. Those in-office procedures are recommended at the same level, just above a level 2 MGD. A lot more and more people are doing them in combination. Now, our practice actually doesn't have IPL, not yet, because IPL and LipiFlow are so similar with the way they heat. So at the time we made our decision which to buy a few years ago, there were simply more peer-reviewed publications on LipiFlow. So that is not the case now. There are plenty of peer-reviewed publications for both technologies. They both work quite well. The other reason is you have to be a little careful with IPL with changing the color of the skin of someone who's darkly pigmented. And we just didn't want to worry about that, though the vast majority of patients do fine with IPL. We just said, we're going to go with this technology. So we don't have every single thing that I showed, but I showed things that are in common usage and have supporting scientific literature proving that they work. So bundling BlephX with one of the other two methods, or now with Tear Science or iLux, is more and more common because the BlephX microblepharoexfoliation uncaps all those plugged meibomian glands. It gets rid of the biofilm that is completely clogging the orifices. And so for the first time in the patient's life since they were born, they have no biofilm on the edge of their eyelid. And soaks and scrubs at home are helpful, but nothing gets it off like microblepharoexfoliation. So now that their glands are open, moments later you move right on to heating the glands and expressing the material. And it's a 1-2 punch. 1 + 1 = 3. It's terrific together. We don't do them separately anymore unless there's a patient from the past who remembers that they used to get just BlephX or just LipiFlow.
Perfect. Thank you. On a related note to that question, is there a certain point at which you would stop using LipiFlow or a similar treatment option?
No. When you see how effective it is, and there are now data from Thomas John, there's a great paper, proving that LipiFlow is more effective than soaks and scrubs and all of it, and maintaining the health of the remaining eyelid glands. So I've started it earlier and earlier. So I will start it as early as early level 2, Meibomian gland disease and dry eye. And a lot of patients, you put them on the recommended regimen and they look at you and say, you got to be kidding me. I'm not going to spend my day doing this. Or they'll do it and come back and say, I did your regimen, and I feel better, but not perfect. What else have you got? So, I find myself, because it's so great and because it's the most effective way to maintain the health of their last few Meibomian glands, I'm mentioning it earlier and earlier and earlier. And it's an out-of-pocket expense. And I find that, when you explain to them that it has actually gone down in cost over the last few years, the cost of goods has gone down. The lipid flow activators have dropped precipitously in price as the company found another manufacturing facility. So they pass the savings on to the doctors, and most doctors pass the savings on to patients, so more patients get it. But it's always important to mention with any of these things that we understand this is a big cost to you. Most patients fill out a care credit form and pay a little bit each month with no interest for 2 years. I always make sure to say that, even though, of course, we've got coordinators who will elaborate. I always say most of our patients finance it because you don't want them to feel self-conscious, like, oh, am I the only one here who can't write a check for this? They're reassured that they can pay a tiny bit each month for 2 years. And of course, care credit takes that burden off your back. That's not a loan carried by the practice.
Perfect. Thank you. Do you screen every patient for dry eye?
I do. And the reason is, that everybody who comes in gets the questionnaire. And as I mentioned, if there's even one symptom that they checked off, that allows for tear osmolarity and MMP9. And that takes the tech just a moment. Now, the MMP9 does cook for 10 minutes. The little cassette sits there. Tear osmolarity takes seconds. So while the tech is doing the rest of the exam, refraction, et cetera, the cassette is developing. It takes 10 minutes. And anybody with an MMP9 that's strongly positive or a tear osmolarity above 325 just gets a Keratograph 5M automatically. So I walk in and they've got all these 3 tests done.
Perfect. How do you maximize the capability of the Keratograph 5? Do you change which tests you perform on patients based on their MMP9 score or their presenting reasons?
Well, I will say that I sometimes use all of them, but the ones I use most heavily are Meibomian and the automated tear film breakup time. They're incredibly impactful to the patient, and they help me see response to therapy. The others are wonderful, and I've done them on many occasions, but those are the 2 workhorses, in my opinion. Of all the tests, those are the 2 that are most useful to me and the patient.
Perfect. Thank you. One more question we have from a doctor in regards to the Keratograph. And actually, in terms of screening, which is your preferred dry eye questionnaire? You'd mentioned this earlier, but let's just go ahead and restate that.
The SPEED questionnaire. If you Google it, just capital SPEED, and I forget what the acronym stands for, but it's speedy. It takes the patient maybe 20 seconds to fill it out. They're not annoyed by it. Some of the longer ones, like the OSDI, they're much longer, and some patients get annoyed with it. And the full version of the OSDI even had questions about what your income is, all sorts of things that, I don't want to ask. So more and more people in their private practice are using SPEED, and it is validated. If you ever wanted to go back and do a retrospective analysis of your results and publish it, SPEED would be acceptable to any of the peer-reviewed publications.
So perfect. Thank you for that answer. I have a couple doctors asking more about the MMP9 and the osmolarity testing and what level of ocular surface disease these indicate based on the results and how that changes the way you initially do further testing and treat the patient.
Okay. So for a long time. I've had a scheme that I use that closely reflects the Dews Workshop, Ascaris, Cedars, Aspens, very similar. But for instance, with if somebody has totally normal tear osmolarity, let me back up even further. If someone has no symptoms at all, we don't do these tests. That's rare now because the Dry Eye Center of Excellence has been open for almost 7 years now at our place, and almost everybody who comes to see me, even if they're coming for cataract surgery or laser vision correction, almost everybody has dry eye. But if somebody comes in with no symptoms, they don't get these tests. If they come in with a positive symptom, and this is a little frustrating because we know half of people with significant dry eye have no symptoms. But there is a Medicare ruling, which is respected by all the insurance companies, that you can't have a blanket order for tests. You can't say everybody today is getting a fluorescein angiogram. You have to base it on something. So if they have even one symptom, then they get tear osmolarity and MMP9. And so a tear osmolarity of so 290 to 295 is normal. 296 and higher, I start treating minimally with just gently preserved tears 4 times a day in omega-3s. When they hit 317 or higher, they get Xiidra or Restasis. When they hit 325 or higher, we switch to preservative-free tears, and instead of 2 times a day, it's 4 times a day. And they usually by then have gotten punctal plugs at that stage, punctal plugs. When they hit 330 or higher, they get the Sjogren's test, the SHO test from Bausch & Lomb, because that's getting to be a really high osmolarity score. And then when people, by the way, tear osmolarity cuts off at 400, the machine goes tilt at 400. So if you're going north of 330, you have an exceedingly dry eye, and half of them have no symptoms. They'll have blurry vision because of all the SPK. And when you tell them they have dry eyes, or they'll have excessive tearing, I spend an enormous amount of time talking to dry eye patients, trying to explain to them that the reason they have excessive tearing is that their eyes are dry. So the short version is to say, you don't have enough baseline tears, your eyes are covered with dry spots. When your brain realizes that you have a critical number of dry spots and that your eyes have been injured, your brain sends the command for the emergency tears. So that's why you have these explosive episodes of tearing. So you need to have more of the baseline tears. That's the kind of short way to explain it. But because the vast majority of them also have Meibomian gland disease, so I use, and the MMP9, by the way, helps. For instance, suppose somebody has a normal tear osmolarity, they have terrible complaints, normal tear osmolarity, and a positive MMP9. That means this eye is inflamed because of the MMP9, but it's not dry eye because otherwise their osmolarity score would be high. So that means go back and look again. You missed some form of inflammation. The most common situation there is ocular allergies, but it could also be lag ophthalmos or epithelial basement membrane disease. But it means it's not dry eye. Go back and figure out why this person's unhappy. So they work beautifully together. So I quickly come up with where they are on the dry eye scale, and I also quickly come up with where they are on the Meibomian gland disease scale. And that's where Meibography is so helpful, because some of it is non-obvious. And, you push a little and you say, okay, a lot of times you get nothing coming out of the glands. I put my thumb in the middle of their lower lid and give it a push and nothing comes out. That's not good. It should be clear oil coming out. Or a cottage cheesy material comes out. That's not good. So I have a very, very high percentage of my patients get Meibography, and that usually starts with, it does start with a 317 or higher score on tear osmolarity and or a positive MMP9. Then they get Meibography. And then I have so many thousands and thousands of these pictures, it's shocking sometimes how much Meibomian gland disease there is when it's not obvious. They don't have a red rim to their lids. They don't have a lot of neovascularization, but there the picture shows the disease that's causing the problem. And then, of course, there's the Meibomian gland workshop. You know, at level 1, you're just having them do soaks and scrubs. At level 2, you're considering all these in-office treatments, and you're adding erythromycin or bacitracin ointment at night. High level 2 going to level 3, they get at least a month of low-dose doxycycline, et cetera, et cetera. So each patient gets a quick, and it doesn't take long for this to be almost really almost automatic, almost without thinking. In seconds, you know what their dry eye score is and their blepharitis score. And some patients have more of one than the other, but most have a degree of both.
Perfect. Thank you. I think we have time for one final question. How do you present the amniotic membrane to the patient so that they're comfortable with the treatment?
So by the time somebody needs an amniotic membrane, they are in trouble, and they are desperate, and they're uncomfortable and unhappy. And so I'll say, you know, we have a treatment for your level of dry eye, and it's wearing an amniotic membrane contact lens. Actually, it's a very thin plastic ring with the amniotic membrane suspended across it. Now, at this point, some of the patients look alarmed because they think this is stem cell research. And I say, this is not stem cells. This is just the inner part of the placenta that's closest to the baby. And it's completely chock full of growth factors that will help you heal. By using this, we are harnessing the tremendous power of fetal healing. So you're going to wear it day and night, and it's going to dissolve and drive these growth factors into your eye. And when I take it out, most of the time, it has already dissolved, and you're just wearing a little ring. I say 5% of people find that it's uncomfortable to the point where they want it taken out immediately. 95% of people have lens awareness, but it's not painful. So I say, what do I mean by that? I'm aware that I have shoes on. I can feel them. I'm aware I have a belt on. I can feel it, but it doesn't hurt me. You will know that it's there, but only 1 out of 20 will think it's painful. So I'd like you to stay here in the office. You can watch TV in the lobby for 20 more minutes because I want the proparacaine anesthetic drops to wear off. And then we'll know if you're in the 5% or the 95%. And just tell if you're fine, just tell my technician or the front desk and you're out the door. If you're not fine, I'll take it out immediately. And it really is 1 out of 20 at most. It's all about setting expectations. It's all about telling them you are going to feel it. We just don't want it to be painful. And it's amazing. It's just a great therapy. I have, by the way, people who are working only because they get periodic amniotic membranes. And it's just a godsend for severe dry eye.
Perfect. Thank you, Dr. McDonald. That's all the questions we have time for tonight. Thank you, everyone, for sticking around, and to those of you who sent in questions. I know we didn't get to all of them, but go ahead and send us emails at sales@oculususa.com if you have any follow-up questions that we didn't get to. We'll go ahead and send out the recording in just a day or two. You'll receive a webinar link so you can rewatch this at any time. Thank you, Dr. McDonald, for your excellent presentation and for your added discussion at the end.
My great pleasure. And if you get any emails you'd like me to answer, Matthew, I'd be glad to do that. Just forward them to me.
Thank you so much. Bye, everyone.
Bye-bye.